last presentation by Dr. Shajena from Medicine 3. And the topic is blood, sweat, and tears.
While she's just getting her presentation ready, I just want to introduce Dr. Shanta Rose. She's a medicine faculty who's an endocrinologist and does obstetric medicine in Flinders in Australia, Adelaide. So welcome, Shanta. Thank you for being here.
Good morning, everyone. I'm presenting a topic of blood, sweat, and tears in behalf of Medicine 3. So this is one antenatal patient admitted in IWAT. She is Mrs. Madhulika, 37-year-old housewife from Chittoor. She is gravid to para 1 living 1 at 26 plus 1 weeks of gestation. She presented with antenatal risk factors of previous LSCS with advanced maternal age of 37 years. Obstetric history wise, her first pregnancy was in 2018. She was 39 weeks. She didn't have any antenatal risk factors. Blood pressures and sugars were at normal range. And she underwent emergency LSCS in view of category 2 NRFS. She delivered a 3.5 kg baby, and a postnatal period and post-op period was uneventful in the first pregnancy. And this is the second pregnancy. In this antenatal visits, all the antenatal visits, the blood pressures and sugars were at normal range. So on 26th, on 6th of this month, she presented to a casualty with complaints of multiple episodes of vertigo, vomiting with vertigo, followed by imbalance while walking and swaying towards the right. Following with the next day, she also had complaints of hiccups with further worsening of imbalance, requiring one person assistance to walk. She also gives history of occasional coughing while having food and intermittent mild headache with blurring of vision on looking to the right. There was no history of fever, or transient weakness, loss of consciousness or seizures. There is no similar history in the previous pregnancy. There was no risk factors of cerebrovenous thrombosis also. Family history-wise, she got married at 30 years of age, non-consanguineous marriage. Father expired at 55 years of age because of heart attack, and mother is alive and well with no known comorbidities. Past history-wise, there is no known comorbidities. She is not a known diabetic, hypertensive, seizure disorder, asthmatic. Personal history-wise, normal bowel and bladder habits with normal appetite and sleep. No history of substance abuse or addictions. There was no history of alcohol consumption or smoking. General examination-wise, pulse rate is about 82 per minute. Normal volume in both upper limb. BP is about 120 to 180, 120 by 180, and respiratory rate is about 22 per minute, and she was saturating 100% in room air. And she is afebrile. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or periodic edema. CNS examination-wise, higher mental function is normal. The cognition, orientation, memory, and normal. Cranial nerve examination-wise, visual acuity is preserved. Bilateral pupils equally reactive to light. Visual fields is normal. Gaze evoked nystagmus on looking to the right is present. Right-sided ptosis was present, and all other extraocular movements were normal. Right-sided sensory loss, right-sided facial sensory present, and motor function is normal. Both loss of pain, temperature, fruit touch was present in the right side of the face. Absent gag reflex was present in the right, and palatal and uvular movements reduced in the right side. Shrugging of shoulders present, and tongue movements of normal. Other examinations like biceps, triceps, reflexes are normal, and bilateral plantar was flexor. Motor examination wise, normal tone, power was 5/5 in both upper limb and lower limb. No drift in upper and lower limb. Sensory examination wise, reduced perception or to pain and touch in the left side of the body. Vibration and proprioception is well perceived. It's reduced about 80% of pain and touch in the left side of the body. Cerebellar signs, dysarthria present, finger nose testing was impaired in the right side, intentional tremors present, heel chin testing is impaired in the right side, and she has ataxic gait which needs one person assistance to walk. So what are the differentials considered in this persons? So summary, she's a 37-year-old, gravid to para 1, living 1, 26 plus 1 weeks of gestation with advanced maternal age with acute neurological deficits with clinically localized to right lateral medulla. See, we came to a conclusion of in the right lateral medulla because of the involvement of vestibulocochlear nuclei, which is responsible for the vertigo, nausea, and vomiting, and the sympathetic descending sympathetic tract involvement because of the ptosis she has, and the right inferior cerebellar peduncle involvement because of the ipsilateral ataxia she has. So the differentials considers were acute CVI because as she is not hypertensive and all her blood pressures are normal in the previous pregnancy also. So hemorrhagic bleed is ruled out, and we thought it's embolic stroke because of ASO, because of may have ASD or PFO, cerebral venous thrombosis, and vascular malformations, which are very rare cases, and bleeding disorders. So the investigations on presentations, HP is 11.4 with normal counts and platelets. Electrolytes were normal. Creatinine is 0.56 and LFT and BBVS ECG showed sinus rhythm. All other investigations were normal. So we went ahead with MRI. MRI showed multiple areas of blooming noted involving the bilateral cerebral hemispheres, brainstem, both cerebellar hemispheres, suggestive of cavernomas. So there are features where chronic hemorrhage with gliosis, and there is a lesion in the medulla extended to the right inferior cerebellar peduncle, suggestive of acute hemorrhage and measuring about 19 into 70 millimeters. Overall features suggestive of multiple cavernomas with overlapping hemorrhage in the lesion in the medulla. So how will you approach this patients in pregnancy, cavernomous malformations? So cavernoma is a presence of capillary vascular malformation without an interposition of nervous tissue. These are actually dilated sinusoidal channels lined by a very single thin layer of endothelium with intervening brain parenchyma. This can occur anywhere in the CNS, including the brainstem and spinal cord. So this is a study done in United States regarding the prevalence of stroke in pregnancy. This study included 16,000 patients, in which our patient belongs to the 35 to 39 category, 35 to 39 years of age, in which the prevalence rate is only 62.5 in 1 lakh pregnancy women, out of which in this 16,000 stroke patients in pregnancy, not even a single case reported for cavernous malformation. So the prevalence of cavernoma, the incidence is about 0.4 to 0.8 in the general population. That itself is in the general population. So this itself is very rare. Incidence of bleeding is about 0.6 to 11% per year, and the rebleeding risk is about 4.5% per year. So the most common presentations of this cavernous malformations are, most commonly these patients present from third to fifth decade with seizures. Most of the patients will be asymptomatic. They would be incidentally diagnosed in any of the MRIs. And some people present with CVA with intracranial hemorrhage and CVA due to mass effect of the cavernoma without any bleed. So the hemorrhage risk of cavernoma increases if there is a associated venous anomalies and malformations if the diameter is more than 1 centimeter. This is regarding to this study. So the genetics, most of the cavernomas are sporadic, about 90%, and it has a familial predisposition also. It is autosomal dominant, which involves genes of 7p, 7q, and 3q. Out of which the 3q chromosome, the cerebral cavernous malformation, 3 gene mutation on 3q chromosome is the most common, and this has an increased bleeding risk even in pregnancy. So this is one case reported. This is one case reported series which is published in 2021. This study is about 62 operated women with cavernous malformations. Surgery was carried out in pregnancy in 7. So only 9 out of the 62 operated women, only 9% of percentage is diagnosed before pregnancy. So hence the study is showing most of the patients presenting during pregnancy. So hence the diagnosis pre-pregnancy is difficult. Measures to prevent the complications of cavernous malformations during pregnancy and the child delivery is difficult. So this is according to the literature review in 1998. According to the case report, pregnancy, which is highly influenced with a lot of hormones, including estrogen and progesterone, they also has a high vascular growth factors during pregnancy, which is VEGF and fibroblast growth factor. This is actually needed for the placental development. These also induce angiogenesis in the cavernous malformation that leads to growth in the size and also increased bleeding. Incidence of bleeding is high, is what we thought prior to the lot of reports. But another one study in 1998, it also shows risk of hemorrhage is low because these lesions are very low flow vascular malformations. So they don't present in pregnancy with increased risk of hemorrhage is what one study is showing. And this is a recently updated study in 2000. This study was conducted in 2018, in which 12 cases of intracranial cavernous hemangiomas are operated in 10 years. They're selected in that study. Out of this 12 cavernous hemangiomas, we did an immunohistochemical study in which they showed there was no estrogen and progesterone antibodies. So this no nucleopositivity found in the vascular walls and the endothelial cell in all the 12 cavernous hemangiomas. So this study is showing us there is no risk of incidence of bleeding, or there is no growth in size during pregnancy. So basically the cavernoma bleed is not related to pregnancy. It can bleed anytime is what is this study is showing. So diagnosis wise, MR imaging is a gold standard study for cavernous malformations, but contrast enhanced MRI is contraindicated in pregnancy, but which is more useful for diagnosing. Especially in the first trimester of pregnancy, this is contraindicated. But if the surgery is planned or adequate evaluation needed, we can go ahead with MR gadolinium enhanced in view of risk-benefit ratio. So treatment, there is no such guidelines for cavernous malformations. It's unclear and still controversial. This needs further research to come to a conclusion. So this study done in 2021, which is showing surgery is recommended for patients presenting with intractable seizures. And if the brainstem bleed, if there is a secondary hemorrhage in the brainstem. So if there is a first brainstem hemorrhage, we don't have to operate. So the and in case of rapidly progressive clinical symptom, asymptomatic single lesion, which is surgically accessible, also we can operate, because to reduce further bleeding and also to avoid long and expensive follow-ups. So surgery which is not recommended is asymptomatic cavernomas, which was single or multiple, which is sitting in the deep eloquent areas. So weak, as I explained, weak recommendation for surgical intervention in brainstem and spinal cord cavernoma if it's bled once. If it's a secondary hemorrhage, we have to go. So there is one more option for radiosurgery, that is SRS. It is recommended in rebleeding areas which is inaccessible, like spinal cord and the midbrain structures. Not recommended for radiosurgery is asymptomatic cavernomas, surgically accessible cavernomas, and familial cavernomas, which are multiple. So this is not recommended because this radiosurgery has its own risk of radiation-induced necrosis of about approximately 27%. So how will we approach cavernous malformations in pregnancy? This is also not a guideline. This is a reported article which is done in 2021. Cavernous malformation, if it's not symptomatic, you can observe. And if it's symptomatic, the guidelines say this case study shows we have to terminate the pregnancy if it's symptomatic. And you have to go ahead for the surgery. So if it's significant and it's progressive, assess the pregnancy week. If it's less than 31, go ahead for surgery. But if it's more than 32, you can deliver the baby and operate at the same sitting. And if it's not clinically progressive, you can still absorb. But it says we can give an option of terminating the pregnancy, but when to deliver the baby. But in our case, our lady with 26 plus 1 weeks of gestation, we have not given the option of termination of pregnancy because there is no clear-cut evidence showing. Our studies are previously in 2018 and 2019 studies are showing there is no risk for hemorrhage in the pregnancy. So we are still waiting till 32 weeks, and we are planning to deliver the baby at 32 weeks, and if the fetal weight is more than 2000 grams. So the mode of delivery is still again controversial. Some studies showing we can go for vaginal delivery, and some studies which is not some studies showing we can go ahead with cesarean section because there will be increased risk during labor and in delivery because of the Valsalva maneuver, and the hyperventilation during the pregnancy during the labor period will increase the risk of bleeding, is what the report says. So in our patient, we have not initial presentation during initial presentation for this cavernous malformation is in the current pregnancy. Previous pregnancy, she didn't had any manifestations regarding this cavernous malformation. So now she didn't develop any new. We are not going for surgery now, surgery for cavernous malformation, and also we are not planning to deliver her now because we are planning to deliver as early as 32 weeks. And after that, we'll repeat. If in between, if she has any clinical deterioration, we are planning to do surgery at that time. At the same time, we are planning to deliver her at the same time. Thank you.
This patient presented to us at 26 weeks with lateral medullary syndrome. Shows the Cavernoma with a bleed. There are actually no clear-cut guidelines saying this is what you need to do, and all the evidence is based on case reports. So we had an MDT with neurology, neurosurgery, obstetrics, and ONC. And we decided to keep her on close observation. If she has any worsening of new symptoms which she develops, to plan for the urgent surgery. So that will a rebleed is a definite indication for a surgery, but the first bleed is a very weak recommendation. And for the fetus to develop, we thought we'll wait till 32 weeks, after which to deliver her and then proceed for the next surgical. The other options which we discussed was one was whether to do a stereotactic radiosurgery, but the discussion was that it takes time for that to act, and we're not getting anything extra. The mode of delivery is again controversial, vaginal versus LSCS. In our patient, because she had previous LSCS, it makes the decision making a little more easier for us when we are going to go into this resection.
I think the other thing that weighed in heavily was the fact that it was in the medulla. So if it's in the medulla, post-surgery, your deficits are going to be a lot more and it's more dangerous. She may be left in a vegetative state. So if you look at risk versus benefit, you have to kind of hold your breath and keep her. So she's in the ward, she's going to be in the ward till about 32 weeks. Anytime there's a deterioration, then there's a clear indication to put her through that risk because it'll be life-saving. But otherwise, to electively do it, that was the main one of the main factors that kind of weighed against it.
What's the long-term prognosis after the delivery?
So it's basically very low pressure bleeds. It's because it's capillary. It's not like your venous or arterial bleed. So that's what I understood from it. But overall prognosis, long term, can they rebleed? Yes, they can.
If someone has a bleed once, there's around 4 to 11% chance of them having a second bleed. So she definitely needs that address, but whether during pregnancy or after pregnancy. And so now the current plan is to 32 weeks deliver her, and after that plan for either a surgery or a radio surgery for the patient.
No, the long term is that because there are multiple cavernomas again, it is, I mean, and hers is in the medulla, and I don't know if the MRI can be put, but it's in the medulla. So that is what kind of prognosticates not very well for her compared to the others.
The other question was because there is a 5% chance of it being a familial cavernoma, and that is autosomal dominant. So the baby also has a risk of
That is good.
So does she have any other family history with the
birth.
There's a father who's passed away
Uh,
early.
MI.
MI. But
Uh,
MI, not really
not
yeah. So
Medical
we don't
genetics,
know.
medical genetics has seen, huh? They don't have the testing for it, they said they'll do a DNA banking.
Any more questions? No. So thank you everyone for coming today and for those who have joined online. And I also appreciate the efforts of all the presenters today. All the presentation was very good and informative. The prize I want to give to Dr. Shajena.